This conference will now be recorded.
This conference will now be recorded. I like to add videos in because I really believe in learning in other ways other than just listening to me talk. Not that I'm not awesome. Okay, so immunity. So our immune system is the real MVP, y'all. So your immune system consists of things that are both innate and adaptive, right? Um, our immune system really serves to keep you free from microorganisms, right? Your body is protected from internal threats. Helps to maintain your homeostasis. Um, and your primary immune response, when we think about white cell count, is going to be your T cells and your B cells, right? But even before we get to that, there are other things. You have your humoral response and your cellular response. So, what is your largest barrier to infection? That's right, good Sister Georgia. It is your skin, right? Your skin is your largest barrier to infection. Um, so a lot of your response is to seal off any holes, right? Because that's going to be one of the best ways to keep infections out. We have different types of immunity. Like I said, your innate immunity, things you were born with. So think about your skin, your tears, your GI system. You are born with all those things. Your inflammatory response, and then what we call acquired immunity, the immunity passed from mother to child, the immunity that you get from being vaccinated, the immunity that you get from being sick. Right? These are all different types of immunity. So we have, let's see, we're totally skipping this slide. That one too. I have a video that I want you guys to watch because it's really great. So just a minute, let me find it. I love YouTube because it has all the things.
Protects it from various types of threats. Our body has a powerful army that protects it from various types of threats. These threats can come in the form of mechanical injuries, the entry of germs, or the entry of other foreign particles like dust. This personal army is called the immune system. Every day, we encounter a huge number of bacteria, viruses, and other disease-causing organisms. However, we don't fall ill every other day, which is due to our immune system, an army of cells that is always roaming our body, ready to ward off any attack. The immune system can be broadly divided into two parts, innate and adaptive immunity. Innate immunity, or non-specific immunity, is the body's first natural defense to any intruder. This system doesn't care what it's killing. Its primary goal is to prevent any intruder from entering the body, and if it does enter, then the immune system neutralizes this intruder. It doesn't differentiate between one pathogen and another. The first component of this defensive system is our skin. Any organism trying to get into the body is stopped by the skin, our largest organ, which covers us. Secondly, there is the mucous lining of all our organs. The sticky, viscous fluid traps any pathogens trying to get past it. These are the two physical barriers. However, we also have chemical barriers, such as the lysozyme in the eyes or the acid in the stomach, which can kill pathogens trying to gain entry. The genitourinary tract and other places have their own normal flora or microbial community. These compete with pathogens for space and food, and therefore also act as a barrier. The next line of defense is inflammation, which is done by mast cells. These cells are constantly searching for suspicious objects in the body. When they find something, they release a signal in the form of histamine molecules. These alert the body, and blood is rushed to the problem area. This causes inflammation and also brings leukocytes, or white blood cells, which are soldiers in our body's cellular army. Once they come, all hell breaks loose. Sometimes, however, the intruder may not be a germ, but rather a harmless thing like a dust particle. The body still causes a full immune reaction to this intruder, which is how allergic reactions occur. In the fortress of our body, the leukocytes are VIPs. They have an all-access pass to the body, except, of course, to the brain and spinal cord. Our leukocytes come in many types. Those that belong to the innate system are the phagocytes. These cells can either patrol your body, like the neutrophils, or they can stay in certain places and wait for their cue. Neutrophils are the most abundant cells. They patrol the body and can therefore get to a breach site very quickly. These cellular soldiers kill the infectious cell and then die, which leads to the formation of pus. There are also the big bad wolves, or the macrophages. These cells are like hungry, ravenous monsters who simply engulf unwanted pathogens. Instead of roaming freely in our blood, they are collected in certain places. These cells can consume about 100 pathogens before they die, but they can also detect our own cells that have gone rogue, such as cancer cells, and kill them too. Beyond that, we also have the natural killer cells. These cells can efficiently detect when our own cells have gone rogue or are infected with, say, a virus. NKCs detect a protein produced by normal cells called the major histocompatibility complex, or MHC. Basically, whenever a cell isn't normal, it stops producing this protein. The NKCs move around constantly, checking our cells for this type of efficiency. And when they find an abnormal cell, they simply bind to it, release chemicals, and destroy it. The last cells of our innate immune system are the dendritic cells. These are found in places that come in contact with the outside environment, such as the nose and lungs. They are the link between our innate and adaptive immune system. They eat a pathogen and then carry information about it to our adaptive immune system cells. This information is produced and shared in the form of antigens. Antigens are the traces that pathogens leave behind. They are molecules found on the surface of pathogens that can be detected by our adaptive immune system for recognition. The dendritic cells pass on this information to our T cells. However, macrophages can also perform this function. Now, there is also the adaptive or acquired immune system. This system is more efficient as it can differentiate between different types of pathogens. It has two main components, T lymphocytes and B lymphocytes. T cells come into play when an infection has already occurred, thus bringing about the cell-mediated immune response. B cells join the fight when the pathogens have entered, but haven't yet caused any disease. This is called the humoral immune response. Some T cells take signals from the dendritic cells or macrophages and are thus called helper T cells. They form effector T cells, which are basically cells that cycle through the body and call in the cavalry, namely other white blood cells. Helper T cells also form memory T cells, which keep a record of this antigen for future reference. Sometimes, some cells of our body know that they have lost the battle. They have become heavily infected with pathogens, so there is no hope left for them. At this point, the immune system brings out the cytotoxic T cells. These cells rush over and perform a mercy killing for the infected and dying cell. Furthermore, we have the B cells. They produce chemicals called antibodies, which fit on the antigens of pathogens, much like how a lock and key fit together. These antibodies crowd around a pathogen and act like tags. They signal the macrophages to come and kill the marked pathogen. B cells also produce memory B cells when they encounter an antigen. The B and T memory cells jointly maintain a record of all encountered infections, and thus strengthen and solidify the body's immune response to these infections in the future. Our innate response is quicker, though non-specific. It gets into action within hours and is pretty strong. However, When things get out of hand, the innate system calls for help from the acquired immune system. This system can take days to mount a response, but the next time we encounter that pathogen, it won't make us get sick. In short, every day that we spend being healthy is all thanks to our immune system, so it definitely deserves our respect.
Okay. Thanks, Naomi. Let me remember to put that in the chat. I don't understand how y'all getting lecture and y'all running up and in and out the house. So, anyway, so there are a couple of different tests that we use in the lab, not so much to measure your immunity, but some of immunity you have to realize is actually manifested in things you are allergic to, right? So anybody have really, really bad allergies? Amasa, what are you allergic to? Grass. I was just talking about that. So for you, how does your grass allergy, is it like you can't go outside and roll around in the grass? How does that work for you? Pollen? Yeah, I'm sorry. It's hard for y'all pollen allergy people, man. Can't enjoy no flowers. So, okay, so for some people, being allergic to grass means that they can't sit down in the grass, right? For some people, being allergic to grass means that they can be around cut grass. Like somebody could be cutting grass and it's gonna cause their allergies to flare up. I'm not surfing. Um, For some people, it can be they can smell cut grass, right? And it will make their allergies flare up, right? So here's the video that I just showed. I accidentally closed my screen and I forgot. So it's the same thing. Who said they're allergic to mud? How does that work? So no, you not going to Colombia to do the mud baths, or you can't have mud mask, or because all mud is not created equal. Some of this mud we pay for. Oh, so you're allergic to free mud. You know what? Same, because I don't want that on me either. Um, so one of the ways, like you'll see people and they just have allergies, but they're not really sure what the allergy is. So one of the ways that they can ascertain your allergies is they do what's called a scratch test. So they have like this chart. It has like little substances. It has little names on it. I should have found a picture of it. I'm sorry. It has little names on it and different like little cutouts where you can physically scratch the skin. And they put it like on your back, right? Because that's a big place. And then they kind of scratch you and introduce a little bit of that agent into your, onto you. So when they do these scratch tests, it's really to try to figure out what you're allergic to. Now, for some people, this works great. We can find out that you're allergic to grass or puppies or cats or whatever. And for some people, it drives their body into this kind of heightened immune response where now it looks like they're allergic to 57 things, right? Um, One of the things we worried about when looking at allergies are things that we use in medicine, like latex. We worry about people being allergic to seafood because that's essentially an iodine allergy, and we use betadine all the time to clean you. We worry about people, you got those people that I'm allergic to Benadryl. No, ma'am, you're not. Or we have people that you just see these laundry lists of allergies, people that are allergic to strawberries. If you're allergic to eggs, that's a problem because there may be some vaccines that you can't get, right? So you don't always think about like, oh, this person is allergic to eggs. You don't immediately connect that with the fact that maybe they can't get a flu vaccination because we that's how we grow some of these vaccinations are contain some of these compounds. So when you get like the skin test to test for the allergen, the person will have either like a local response or a systemic response. So sometimes your local response, like I'm allergic to mastosol for some reason, and my local response to mastosol is that I get a rash where I've put the mastosol and then it radiates out, I guess until it gets tired. And it like I put Mastisol, I know I had like a cut on my hand, and the Mastisol rash went kind of halfway up my arm. Um, so that's more of a local reaction. More of a systemic reaction would be sneezing, your eyes burning. Um, One thing we really fear anaphylaxis because that's just definitely not great. Your throat could swell and close. So there are levels to allergies. Some people itch, some people have anaphylaxis based on different things. But it's an individual response. You can manage allergies. Local allergies can be managed with ointments, creams, compressions, a nice oatmeal bath. Um, my friend Amante has to get a shot every month for her grass allergy because you kind of can't avoid grass. I mean, even if you live somewhere like New York, it's gonna be grass. You live in Vegas, it's 7 pieces of grass in Las Vegas, I promise you. So some things like you can't avoid because it's constantly in your environment. Um, it was some ladies in the other group that they have like bad allergic reactions to literally sunshine. So they have like a regimen that they take every month. Um, There's always antihistamines, so think about Benadryl, Claritin, anti-inflammatories. That's going to be like 1,000 milligrams of ibuprofen 3 times a day, or steroids, which are going to serve to dampen your immune response. Period. We just talked about anaphylaxis and how not great that is. So anaphylaxis is just this hypersensitive reaction to an allergen. Now this can be systemic or it could be really local. We just said that. So has anybody ever seen anyone in anaphylaxis before? So Georgia, well, see a lot of people. So Georgia, tell me about the person you've seen in anaphylaxis. Oh, stop that with me. No people here. That was exciting. So I had a patient in anaphylaxis. I had been a nurse for 3 weeks. I'm not even playing because I end up my grandson ate peanut. Yeah, your grandson ate peanut butter. His throat closes. Peanuts is like a deadly allergy. Like people I know with peanut allergies have to tote an EpiPen around with them at all times. Yeah, that's terrifying. So the patient that I had, I was working in a jail, and he had just got like admitted to jail. That's not how it works, but he just got arrested in process, and I guess he was non-compliant in his arrest, and he wasn't really feeling that, and yada yada yada. He ended up being sprayed with pepper spray. He immediately could not breathe, and his throat started to close up. Keep in mind that I've been a nurse for 3 weeks at this point. One of my first shifts by myself, unsupervised. And they called me and said, "Hey, this guy is acting like he can't breathe." Well, what did you do to him? Right? They told me they sprayed him with the pepper spray, and he immediately, like, tearing up, coughing, looked like he was choking. So I'm like, what do we give people for allergies? This is me in my head, because keep in mind, I have no idea what I'm doing. So luckily, there was a magic box full of Epi and Benadryl, and I stabbed that man in his leg. And because I mean, I'm at a jail, I have no oxygen, I can't intubate him. And I told them, I said, well, y'all need to call the ambulance, otherwise this is not gonna work. So we had to rush the man off to the hospital. He had to be emergently intubated in the bus, they told me later. And he stayed there for a couple of days. And magically, the police forgot what they arrested him for, and he never came back, which, thank you. So one of the things you always want to do, you want to make sure your patient has a line, right? You want to make sure you have oxygen available. And remember, you can start 2 liters without anybody's permission. You want to give Benadryl and Epi, IV or IM. If you don't have an IV, giving an IM is fine. It just needs to get inside of their body, right? And then, of course, you want to document what happened. And all of this could happen before, like, your backup shows up. You could be the backup. There's nobody else but you, right? So airway, breathing, circulation. So with anaphylaxis, one of the things we really, really worry about is airway. Another allergy that we worry about all the time as healthcare providers is going to be a latex allergy, this hypersensitivity to latex. One of the things we do in the hospital is we have tried to remove latex from a lot of different sources, because latex is a natural rubber. There is latex in everything, in the Foleys, in the PIC lines, like in, the central lines, um, in the gloves. There was latex everywhere. So your exposure to latex can push an allergic reaction, or you could really just be allergic to latex, like from day one. You can't hear me. So, hi. Coming back. Um, so these reactions to latex can be the same. They can be localized reactions, or they can be systemic reactions when you have this allergic reaction. But I know that I work in the operating room a lot, and when we have a patient who says they have a latex allergy, we actually have a special box for the gloves that are not latex. Like, we have special sections of latex-free things, like latex-free Foleys, um, so that we don't exacerbate their latex allergies. For some things, we only have a latex form available. And so what we'll do in that case is, the patient's usually already intubated, we give them some Benadryl. We may give them some Tylenol or something to try to keep their temperature down. But because we can monitor their airway, because they have an ET tube in, we don't really worry about that part. So usually people who are at risk for latex allergies are people who are repeatedly exposed to latex, like healthcare workers. Your beautician wears gloves when she do your hair. She's repeatedly exposed to latex because of that. Auto mechanics, like, they work around rubber tires. People who have had multiple surgeries. I meant to look this up about spina bifida, and I don't know if it's because they have exposed meninges or what, but people allergic to certain types of food, pineapples, kiwis, bananas, different kind of tropical fruit, hazelnuts and water chestnuts, there's a protein similarity there. So those same people will also be allergic to, also have a risk of an allergy to latex. So we talked about these different types of interventions. The best thing is to remove latex from the environment. And like we said, hospitals have really tried their best to remove a lot of the latex containing things. You want to think about risk factors. You want to use non-latex gloves, non-latex supplies. Um, a lot of times we have those things in a cart. If you have a cart, keep it in your client's room. Make sure you put up signs, right? This person has a latex allergy. I know that the blood pressure cuffs a lot of times have latex in them, so you want to put like a cloth or something under their arm so that the blood pressure cuff is not touching their arm directly. Um, Glass ampules instead of like plastic bag. And for the patient, as part of your teaching, if it's important for them to be able to identify themselves as all time as having this allergy. So wearing one of those little bracelets would also be very, very helpful. Um, Immunodeficiency. So there are certain diseases, certain situations, certain medications that suppress your immune response. So being immunodeficient is going to be the absence or the inadequacy of immune bodies. Mostly think about your T cells, your B cells. So you can be born with a type of immune deficiency or you can acquire it. Um, the most common way is going to be you acquired immune deficiency, like you contracted HIV or you are being treated for cancer and it's killing your immune system, right? Or that you received an organ and you have to take drugs that decrease your immune response. Um, the long-term use of steroids will also decrease your immune response. So one of the things we want to make sure that we do for these patients is to try to minimize their exposure to infection. So you really want to protect them from infection. You want to make sure that they don't have a lot of incisions to their skin. You want to make sure that they have good nutrition, they're drinking enough water, they have enough proteins. You want to be very, very clean. Use strict aseptic technique for any procedures that you do to them. Um, think about teaching them about different lifestyle changes. If you are immunodeficient, please don't be out here in these streets getting tattoos and piercings. It's not really safe for you. Um, and instruct them in basically how to kind of break this chain of infection. Just basic things, hand washing, keeping your skin intact. They probably also definitely need to wear a medic alert bracelet. So, thinking about an autoimmune disease, and we saw in the video that sometimes your natural killer cells are just, oh, that looks delicious, but it really could be your pancreas, right? So we have lupus here as this example, but one example of an autoimmune disease is diabetes 1. These diseases where your body is unable to recognize this cell as a cell that belongs there, right? So think about lupus, sarcoidosis, rheumatoid arthritis. These are all examples of autoimmune diseases. Your body is having an inflammatory response to itself. There's really, for most of these diseases, all they can do is treat the symptoms because there's no cure. Um, they know that it's related to some type of immune response, some types of immunological mechanism, but nobody really knows how to fix it. Precipitating factors, medications, stress, genetics, sunlight, pregnancy, walking, breathing, like literally anything can trigger a response in your body. And it's kind of like, I don't like this. So with these kind of disease, you really focus on treating the symptoms. Scleroderma is a type of sclerosis, which means that it's a disease of your connective tissue. So like multiple sclerosis, your body is burning up the sheath that coats your neurons. So this neuron coating makes it so your nerve impulses don't have to travel along the whole neuron, that it skips from break to break, right? So it can go faster, which we like that. So you can move faster. Anybody know anybody with MS? Not muscular dystrophy. Yeah, that is yep, wow, different from MS. So um with multiple sclerosis, like I said, you can have the kind we call relapsing and remitting, right? So it'll get bad, it'll get worse. It'll get bad, it can get worse. Or you can have the progressive multiple sclerosis where it get worse and it get worse and it get worse, right? So in this case, you are really just treating these types of symptoms because the disease is also not reversible in these cases. Um, Polyarteritis nodosa is so your collagen is in your layers of skin, and it kind of serves to protect your organs, and then it serves to like plump you up. Like collagen is like this thing when we talk about your face looking young, that's collagen. So this disease is a form of like vasculitis, so like an inflammation of your vascular system, and it really attacks your visceral organs. So think about your liver, your kidneys. So we kind of treat this. The treatment for this is similar to lupus. We're really just treating the symptoms at this point because there's no cure for it. They do not know what causes this disease, and the prognosis is poor. So nobody is gonna like take a monthly shot of steroid and be okay. The problem, one of the biggest problems is there usually renal involvement and cardiac involvement. Um, Want to mute your mic, Linda?
Yes,
So there's usually renal involvement and cardiac involvement, and we know that treating one usually makes it harder to treat the other. Um, and the interventions are similar as the interventions for lupus. Pemphigus is not one of my favorite diseases, but it's really it's an interesting disease. And hmm, it's an interesting disease because has anybody ever heard of Steven Johnson's? No, okay, Magdala. So like Steven Johnson's is an immune response to some type of medication. We still are not sure. Like some psych meds do it. A lot of times I see it in people who have taken Bactrim. Um, but Steven Johnson's, right? So the only reason I mention it is because pemphigus, it it looks like Steven Johnson's. I've had a pemphigus patient, and I said, "Oh, so he has Steven Johnson's." No, is it warfarin poison? No. Okay. So we still have to, because I'm looking at skin at this point, and it's something you can't really fix. We still treat these patients like burn patients. And our main focus is closing their skin. So these people will present with fragile skin, bleeding lesions, they form crust, they weep everywhere, they can't really get up and walk, they're in lots of pain, and they're very tired, and they're going to have trouble talking, swallowing. Some of this is because it is very possible that there's skin sloughing in their throat, right? So what you get is this separation of your epidermis from your dermis that's kind of caused by rubbing, right? And then the skin is not staying intact. The prognosis for this, it can be fatal depending on what skin is sloughing. Like I've seen patients where it's just on their arms and legs. I've seen patients where the skin is sloughing down their throat. Those people don't have a good prognosis. I've seen patients where it's on their face and feet. I've seen a whole hand deglove in an hour. Like it depends. It can be anywhere, and you never know how bad it is until you see how bad it is. So a lot of times for these patients, we focus on excising the damaged skin, covering it up with like something protective, and really just getting fluids in them. And sometimes we try to treat this with IgG just to kind of dampen that response. Lyme disease is another disease that really, really wreaks havoc on your immune system. It's primarily caused by a tick bite, and the tick attaches to the host, right? So the tick is still alive, living its best life attached to you. So you treating Lyme disease really doesn't work until you remove that tick. So after you remove the tick, you can really start to treat the underlying disease with antibiotics. You want to focus on, a lot of prevention. They get blood tests. It's kind of a disease that once you get it, or once that tick bites you, it can be 4 to 6 weeks before you understand that anything is going on with you. And what it does is it stimulates this inflammatory immune response. So HIV/AIDS is one of the things that we often think of when we think about an immunodeficiency, something that depresses your immune response, right? So AIDS is caused by a virus, and this virus destroys your T cells and which are a really huge part of your immune response, right? So HIV shows up and it targets your T cells and it destroys them. So what that does is it takes away your body's ability to fight back. We consider HIV/AIDS to be a chronic illness because you can live for years with this and it progresses in stages. So it's not like as soon as you contract the virus, you go from fine to AIDS. It don't even work like that, right? It works on your body over time. And then, you see some people what? You see some people back in the 80s when HIV was relatively new, that they can deteriorate quickly based on other things that was wrong with them. And then you see Magic Johnson, who is still out here in these streets living his best life, taking all his medication, fine. But he still has a virus, but it's not impacting his life in the way that it would impact somebody who was not on the same regimen as him. When COVID first came out, we were talking about using antiretrovirals to try our antivirals. Yeah, because we don't have no cancer pill, right? We got a whole package of things for HIV. For antiretrovirals, antivirals to try to be like, well, maybe this can stop the progression of COVID. and we were giving them these same kind of viral pills that we give to HIV patients. Um, with HIV, because so one of the ways that the pill works is to make the virus stop invading your T cells, right? So it can't necessarily kill the virus, it tries to stop it from replicating, you know, because that's one of the important things, to stop it from replicating. Because if you can stop it from replicating, you can build your immune system back up, right? And you wouldn't have the problem with getting these type of, we call them opportunistic infections, like Kaposi sarcoma, which is like a skin cancer that really old men get, that we were seeing manifest in younger patients with HIVs, like especially in like the 80s, the early 90s, when nobody still really knew what was going on. Um, we also have another way that your immune system can be compromised is if you get an organ transplant, right? You get a heart transplant, you get a new liver, you get a kidney. Your body does not know that kidney. Or rather, it knows that it did not come with your original package. So your body sees it as an invader and would like for it to leave. So patients who have received organ transplants have to take an immunosuppressive agent forever. Forever. I mean, and the rate, like let's say you stop taking that pill tomorrow, baby, your body will push that organ out in like 3 months. Sometimes even faster, depending on how far, unless you got it from your identical twin or your brother, right? So those immunosuppressive agents are keeping that organ viable and keeping your body from rejecting it. Now, they are hard on the body. They do mess with your kidneys because that's how they are metabolized. So when you have people in organ, like who just received organ transplants, you really, really have to be careful looking at their CBC, making sure that they are not bleeding spontaneously. Like this is a high risk patient, even if they're stable. Like it's a high risk patient. We talked about different type of medicines that can suppress your immune system or work within your immune system to kill microorganisms. So with HIV, this is a virus, so you have to have an antiviral, right? So mostly the medications for HIV are focused on preventing the virus from replicating itself, right? They have other ones that prevent the virus from binding to cells, right? Because there's a protein marker that you have to have, and you learn a lot about this when you take like a biochemistry class as far as like different protein markers. Um, there's a protein marker that you have to have that allows one cell to connect with another, right? So if you can disrupt the creation of those markers, you can inhibit the binding of that HIV virus to your cell. Um, People are usually on regimens of multiple medications because everything is going to work different for everybody. But you usually approach HIV, fighting HIV from different ways. So you want to inhibit that reverse transcription. That has to do with like your RNA and what kind of protein molecule you're making. You want to keep that HIV molecule from attaching to your cell. You want to make it be quiet, right? And although you can't necessarily kill the HIV virus, you can stop it from being so effective. Does that make sense? There's also medications like you think about PrEP. that you take before interactions, and they're almost kind of a way to prevent you from contracting a virus. So we talked about immunosuppressants for transplant patients to keep them from rejecting their new organ. And we try to also use these immunosuppressants for people with other autoimmune disease, like patients with lupus, patients with sarcoidosis, patients with rheumatoid arthritis, right? So an immunosuppressant can also help these patients. Antibiotics is different from an immunosuppressant because antibiotics, the job of the antibiotic is to come in and kill, is to come in and kill bacteria. Like, but the problem is you have what's called broad spectrum antibiotics, which we really like. And broad spectrum antibiotics is going to kill everything. Like, it's not only going to kill what has invaded your body, but it's going to kill everything. So okay, think about how doctors write these amoxicillin or whatever it is. Okay, so like when you go to the dentist sometimes and you get like it's just dental work, they'll give you an antibiotic. So one of the other things that most women ask for is what? The doctor writes you an antibiotic, and what else do you want? Nobody? A probiotic, or what else? I don't really want a probiotic. I want a one and done, not pain meds. I want a diflucan. I don't know about the rest of y'all. Flagyl, yeah. So you want that because that antibiotic is not just killing that invader, it's killing everything. So when it kills everything, what you now get is a overgrowth of yeast and you get a yeast infection. And nobody wants those. We need that good flora, right? E. coli is great as long as it stays in your stomach. Once it escapes, it's a problem, right? So your body Okay, raise your hand if you can hear me. It wasn't you. All of my lights went out because it's thunderstorm season in Fort Lauderdale. And I was totally, no, my mic wasn't off. My internet was off. Okay, moving on. All right. So antibiotics inhibit the growth of bacteria. What is one thing that we tell our patients when they are taking antibiotics? Right. You need to finish them. But I feel better. You must finish the whole dose. Because not finishing doses of antibiotics are reason that we have, yes, drink a lot of fluid, are reason that we also have resistant bacteria, like TB that is resistant to treatment. Or we have, like when you have VRE, that's vancomycin resistant. What is that last word? I can't remember. Something. Ooh, I just had a patient with this the other day. But that person's on contact precautions, and the medicine that is usually used to treat that disease does not work anymore. Like MRSA, that staphylococcus that's resistant to medication, right? So we create, they call them like super bugs. Like we create these super bugs by not finishing our antibiotics, our course, and then we really overprescribe antibiotics. Like everything don't need an antibiotic. But so we always need to consider these things when we're doing our patient education, when you work at a teaching hospital and you got an intern and you got to teach him and you got to teach the patient, right? So you have to consider these kind of things. I know a lot of hospitals, they do like antibiotic vacations, where they'll pull the patient from, yeah, into a, see, thank you, Alicia. You got all the good nurse words, girl, because I don't be having them all the time. We use so many abbreviations that you forget what the words are. But we all know what we're talking about. That's called jargon, right? So we have to be better. It's called anti biotic stewardship or something like that. I think they call it the hospital I work at now. Antibiotic stewardship. That you want to give the like the you don't want to give a broad spectrum for everything. Like you want to give like the just the minimum amount of protection. So, you know, you want to give like the smallest, most specific antibiotic that you can to cure this specific thing that's wrong with this specific person, rather than throwing all the things out there, right? Because if you use Vanc for everything, what you gonna use when a Vanc don't work? And plus also, what are you gonna use when you kill their kidneys? Right, so those are really important. So we do like tests and we do cultures because we try to see exactly what is wrong with the patient so that we can get the right antibiotic for the job. So one of those things, when you when you're in microbiology class, and we actually did this in my microbiology class, it was really cute. We grew like our little microbes, and then we took little dots of antibiotics to see which antibiotic made the microbe move back. So essentially what that is it's a culture and sensitivity test, because you want to know which medication this microbe is sensitive to, and that's the medication that you want to give. Joanna, unmute your mic. Where you at, friend? Joanna don't even want to, she don't even want to play with us. Hey girl, hey. Do you mind telling us about that criteria? The mid-year criteria. So I know it's for like long-term surveillance of infections. So tell your classmates about that. So I've seen us use it a lot in like long-term care facilities because one of the things that all elderly people like to get is UTIs. And then the UTI always causes a very, very swift and distinct change in their level of consciousness, right? So you kind of look for signs before you start giving antibiotics. Yes, they be confused, right? So that's going to be your CAM, your change in mental status. You also look for a fever. You look for leukocytosis, and you look for like an acute decline in their ADLs. Like if Monday, Mr. Bob was able to get up and brush his teeth and wash his face, and on Wednesday he can't do it, like we have a problem. So if he's gone from like super independence to he can barely get around, or he can't really put the pieces together to be able to complete his ADLs, because that kind of goes with your change in and mental status, because your baseline has changed, right? That's important. We also look for a temperature more than 100 degrees, 100.4. In the hospital, we say 101.1, but I can't let my temperature get that high. That's kind of the blanket criteria for McGear's. But for other things, for like respiratory tract infections, you have some that are more specific. You have specific ones for UTIs um, that are going to include like the change in the urine, and you want a culture. But some of the problems with, so I worked in the LTAC for one day, y'all. One day. That's all I had on me. One day. But I would never forget that we were responsible for collecting our own labs, like spinning our own blood, collecting all our own specimens. And for you think about for patients, how many patients we have on Foley's in these kind of long-term situations. Because we have, so for McGear, we have different rules for people with catheters and people without catheters, right? Yeah, or even flank pain, blood in the urine. Um, if they are increasingly urgent or incontinent, or they have to pee more often, those are signs and symptoms of UTIs. But some of that, like I said, some is specific to like long-term care, because a lot of times in ICUs, you may or may not have a patient there long. In burn ICU, we've had patients for months, but a lot of times you may or may not have a patient there long enough for you to really use that, because it's mostly focused on things for long-term care facilities. And like I said, I worked in the LTAC for one entire day, and I never worked in a nursing home. That was it for me. So this is actually the last slide in this lecture. Do you guys have any questions about this specific content, the immune type of content? So I know it seems like it's kind of like out of place, but one thing I will tell you about nursing education is that it seems weird. It's kind of like after it's over, then all the pieces fall in place. Because if you come from just like outside and you're like, I'm going to nursing school, when everything is new, some things don't seem to make sense when they stand alone, right? And it's later, after you add these immune response into a real med surge patient or a real person that has had surgery, that you start to see like, okay, like I understand this now. I don't know anything about the PowerPoint being in Canvas, but what I am doing is recording this whole lecture. I know Lynette has a PowerPoint, so she will be responsible for putting them in Canvas. So if that's her normal thing that she does, then that's what she do. So for right now, my pleasure. I'm here for y'all. So for right now, we're going to take a break because breaks are great. Um, it is 6:12, right? So you have earned yourself a break until 6:45. When we come back, we are going to talk about genetics, which is super fun. We are going to talk about genetics and how that works. So this break is until 6:45. How do you guys usually access this stuff? I think they're normally in Canvas or on YouTube. Like, I'm not really sure. Y'all, I don't go here. So we will resume class at 6:45. We will be talking about, what will we be talking about? We will be talking about genetics and genomics. Okay, enjoy your break.
This conference will now be recorded.
Thank you. The reason it's important to kind of have this baseline understanding of what DNA is because we use DNA. That I messed up again. So we use DNA, or at least we think about a person's genetic components when we are giving care to them, right? Um, for instance, sickle cell, or having a sickled cell, is a mutation. It is a mutation that happened for people in Africa and parts of the Middle East to protect them against malaria. The last widespread human mutation is the ability to tolerate lactose, right? Because the ability to tolerate lactose was a forced mutation that happened about 10,000 years ago. So when you think about these kind of patterns and how mutations are passed on, there's basically three different ways. So traits can be dominant. That means if you get that gene, you have that disease. Traits can be recessive, meaning that you need to get a copy from each, so one from your mom and one from your dad to have that disease. And then we have diseases that are carried on the sex gene, so they're X-linked. An important example of this is going to be hemophilia, right? That's a sex-linked recessive disorder, hemophilia. Which is why if your mom is a carrier and your dad is a carrier, you're going to have hemophilia. So hemophilia is widespread. You see it in clusters in the royal family. Actually, are you used to in Queen Victoria's time? Because they had so many carriers in the family that it was rampant throughout that family. Um, I lost my place. So when we think about how things are spread, I like, anybody ever heard of a Punnett square? Like, I remember we did like genetic basics in high school, and we did a Punnett square. Have you guys heard of that? Are you familiar? Okay, nobody. So a Punnett square is a really good way for you to kind of make a quick and dirty basic sketch of what is, of like predicting what a child is going to look like. Before I show you that video, let me send you the link to the video we just watched. And now we're going to watch this great, great little video about childhood, like how genetics are passed on. Okay. Okay, let me switch my mic over.
Chapter 2 of the Genetics and Fertility video series from the American Society for Reproductive Medicine. Diseases can be passed down in different ways, depending on the disease and how many copies of a gene a child inherits. When illustrating inheritance, it helps to use a Punnett square. The square is named for Reginald C. Punnett, who devised the following approach. Draw a large square divided into 4 smaller squares. You should have 2 rows and 2 columns. One parent is drawn on the top and one parent is drawn on the side, shown here in gray. The diagram is used to predict the genetic makeup of the children, also shown here in gray. In our example, each square represents 25% of the genes a child will inherit for a particular trait for any child born from the 2 parents. Each parent can pass down one of 2 potential chromosomes. For instance, the mother in this example scenario has 1 chromosome with a mutation in purple and 1 chromosome without a mutation in orange. The mother passes 1 copy of each of her chromosomes down each column from top to bottom. Meanwhile, the father, who has 1 chromosome with a mutation in purple and 1 chromosome without a mutation in orange, passes each of his chromosomes across each row from left to right. Each child has a 50% chance to receive 1 of 2 chromosomes from their father and a 50% chance to receive 1 of 2 chromosomes from their mother. Typically, a child will not receive 2 chromosomes from one parent, and typically a child will not have more than 2 of each chromosome. So the outcome for this scenario means that there is a 25% chance that one child will be born with 2 chromosomes that carry the mutation, and a 25% chance that the child will be born without the mutation on either chromosome. The remaining 50% means that the child will be born with 1 copy of the mutation and 1 copy of the chromosome without the mutation, like their parents. The Punnett square determines the likelihood of having an affected child with each pregnancy. This likelihood is reset for each pregnancy. So even if your child is affected, their siblings will have the same chance of having a mutation or not having a mutation. So, while it is rare for 2 parents with 1 mutation each to have 4 children that all have 2 copies of the mutation, it is still possible. Now that we understand the basics of inheritance, let's look at some of the different types of genetic mutations. Genetic disorders caused by mutations in a single gene are called monogenic. These disorders can be autosomal, meaning the mutation is on any of the autosomes shown here in orange, or sex-linked, meaning the mutation is on the X or Y chromosome, shown here in pink and blue. Autosomal mutations can be either recessive or dominant. Autosomal recessive means that you need 2 copies of the mutated gene to have the disease. Examples are sickle cell anemia and cystic fibrosis. If you only have 1 copy of a gene with an autosomal recessive disease mutation, and your other copy is normal, you are called a carrier. This means you won't have the disease yourself, but could pass it on to your children if the child's other parent is a carrier and has a recessive mutation in the same gene. The chance of each outcome breaks down like this: affected person plus a non-carrier. All children are carriers, no children have the disease, and no children are without the mutation. Affected person plus a carrier. Statistically, half the children will have the disease and half will be carriers. Carrier plus a carrier. Statistically, half the children will be carriers. 1/4 will have the disease, and 1/4 will not have the mutation. Carrier plus a non-carrier. Statistically, half of the children are carriers, and half are non-carriers. On the other hand, autosomal dominant diseases only need 1 copy of the mutation to manifest as disease. For example, achondroplastic dwarfism. With autosomal dominant diseases, the chances of having an affected child are 50%, since a child can be affected by a disease with only 1 copy of the mutated gene from either parent. It breaks down like this. If one parent has 1 mutated copy and the other parent is healthy, there's a 50% chance of having a healthy child and a 50% chance of having an affected child with one mutated copy. If at least one parent has both copies of an affected gene, all children will be affected. This is rare. If both parents have one mutated copy of the gene, there is a 1 in 4 chance of a healthy child, a 2 in 4 chance of getting a child with one mutated copy and thus affected, and a 1 in 4 chance of having a child with two mutated copies. Because this is autosomal dominant, the overall chance that a child will be affected by the disease is 3 in 4. Mutations can also occur in the sex chromosomes X and Y. These mutations can be trickier because depending on the sex, the chromosome pairs are not the same. Men are XY, women are XX. Some Y chromosome mutations can cause absent or low sperm counts. These mutations can be passed down from fathers to sons. Like autosomal mutations, X-linked diseases can be recessive or dominant. This is important because in the case of X-linked recessive conditions, such as hemophilia, the chance of a child having the disease is different for boys and girls. Males are XY. If a man's chromosome has a mutated gene, even if it is a recessive trait, he will have the disease, since that is his only X chromosome. A female has two X chromosomes and would need to have a mutation on both of her X chromosomes to have an X-linked recessive disease. If she has only one X chromosome with the gene mutation and the other X chromosome is normal, she is a carrier. This means she will not have the disease, or she will have a milder form of the disease, but will be able to pass it to her children. The chance of having an affected child with an X-linked recessive disease breaks down like this. Carrier mother and healthy father. There is an equal chance of having a healthy girl, a healthy boy, an affected boy, or a carrier girl. Statistically, this means that half of the children, boys and girls together, will be unaffected. For the other half of the children, the girls will be carriers and the boys will be affected. Non-carrier mother and affected father. All the girls will be carriers since the father can only pass his mutated X chromosome to the girls, while none of the boys will have the disease since the father passes his Y chromosome. An affected mother with two copies and affected father with one copy. All children will be affected. This is rare. Carrier mother with one copy and an affected father. Half of the girls will be carriers and half of the girls will be affected. Half of the boys will be affected and half of the boys will be unaffected. We hope you found this information helpful. For more information about genetic testing in the setting of infertility treatment,
I'm a huge fan of video with graphics that move. I think that sometimes you can read something, but you have to see it in action to sometimes really understand. Why is this not working? Mm, I'm trying to send this link. It's totally not working. Okay, I have it now. But so moving on. A lot of times where you really see genetics come up, and for a reason that is in that here we go. That is actually in that little lecture about like IVF and fertility, because sometimes you have the option when you are in IVF because you have multiple embryos to choose from. Um, so back to our genetic disorders. So the video covered what a mutation was and how a mutation is like a change that happens on one single gene. Um, those are just really regular mutations. Like anything could have caused them. They may not ever repeat again. Mutations on multiple genes are usually caused by environmental factors. There's an area between, the entire area between like New Orleans and Baton Rouge. We refer to it as Cancer Alley because the incidence of cancers, just different type of cancers in that 65-mile stretch is so high, and they contributed to the abundance of petrochemical plants. So the groundwater is contaminated, the soil is contaminated, and the air is contaminated in that area because of those plants, right? That is an environmental factor that is causing mutations in multiple genes. There's also damage to chromosomes. What is one of the most common everyday ways that you can damage your chromosomes? Anybody want to guess? Lots of people do this in the summertime. That's right, tanning. Tanning is damaging your chromosomes. And you can tan to the point where your body is unable to fix the damage, right? Um, and that's both tanning in those little tanning beds and tanning outside in the real sunshine. Like some people think one is better than the other. They are both equally not great. So tanning is a way for you to damage your chromosomes. So people get genetically tested, and usually you'll see this kind of genetic testing happening in people who are trying to conceive or people who have, like I said, the multiple embryos, and then you can actually test the embryos to kind of see which ones are going to be the most viable. So when you conduct a genetic test, super common sense, a positive test means they found something, and a negative test means that they didn't, right? When you get into your mother baby, you'll see some different kind of testings, like amniocentesis is definitely one that they use to test to look for genetic mutations, as well as chronic release sampling. That's one that they use. But the basic categories are a PCR. So how many people had a COVID test? Yes, super fun. So that little swab that they take is it's some DNA in there, right? So in a PCR, it allows them to take that section of DNA and copy it so that they have enough to ascertain if something is present, right? So you can so with the COVID, oh my God, every week, is it for your job? Girl, I can't work there. No, ma'am. Twice per. I'm gonna have to keep working in the computer. I can't do it. Twice a week. So everybody who has a job, or is it the residents too? How is anybody paying for this? This sounds real expensive. Because I know that they don't go up all the way. So them ain't even good tests. They're just wasting swabs. Unless I'm FEMA. So is it it's just like the inside, the anterior nasal, like the flu? Oh, the state. Well, yeah. I actually am terrible. I've only had 2 COVID tests in my whole entire life, and I had them a week apart. I had one before I went to Haiti. No, they go up all the way. A nasal pharyngeal. Oh, I don't like it. I need them to pay for the one where they can swab the inside of your mouth. Oh, baby, I don't like that. Okay, so, well, y'all are super. So, do y'all send them out to a lab? And how long does it take these magic COVID tests to come back? 48 hours. Do you, have you had a lot of people test positive? 3 to 5 days for the PCR. 15 minutes. Okay, come through, rapid test. So I took a test because I went to Haiti. So I took a test before I went on my vacation. They came back in like 24 hours, less than that. And then I took one at the airport in Haiti, like the day that I was flying. And I promise you, it came back in 15 minutes. Positive on the job before the notice for 2 days, right? Rapids are not as accurate. That's true. That's why a lot of foreign countries won't take the rapids if you're trying to go vacation. Yeah, I had well, whichever one I had, I don't know. Oh, it's like an antigen test, I think. Oh, wow. So, okay, so PCR is now like a term that we are really, really associated with COVID testing, right? Because it has become like the gold standard of COVID test, even though, you know, um, who knew there was going to be okay, PCR can take 30 minutes. That's dope. I guess it depends on like the manner in which I haven't really read enough about COVID tests to be like super, super, I don't know all the science. Um, and it seems really stressful. But I've only had 2 COVID tests, and they both came back relatively quickly. Um, so the PCR test is the one in which we rapidly kind of copy the DNA and then do the test based on that. Has anybody ever heard the phrase mapping the human genome? Yes. So in the 90s and the 2000s, this was like such a big thing. We wanted to map the human genome. We wanted to be able to know what every gene did on a chromosome, like where they were located. Um, because I mean, think about the advancements in medicine. If you can know what gene, like your oncogene is on, and you can find it and you can prevent it from turning on and keep people from being from getting cancer. Um, but this kind of, it's called the genome wide association study. They scanned a complete set of your DNA and they look for any genetic variations associated with different types of diseases. And this is only possible because they've been able to map as much as a genome as they have. So you can look not just for specific things like trisomy 13 or Down syndrome. You can look for, like I said, diseases that are influenced by multiple genes, like the tendency to have high blood pressure or di- to become to have diabetes, heart disease, all kinds of things. So one of the reasons that we talk about pharmacogenomics and pharmacogenetics is because we realize that all medications don't work the same for all people. So I was working at this prison when I was in nursing school, and the doctor was trash. And I remember hearing him say that from now on, whatever this magic day was, the only medication he was given for hypertension was Norvasc, and the only insulin he was going to give was 70/30. He didn't provide no rationale. That's just a decision that this man made on a Thursday, and that's what he's going to do. So I want you to think about the population that is disproportionately incarcerated and the fact, see, and we need to turn them into the border doctors, and the fact that disproportionately Norvasc is not the first line drug for Black people. But this is what he decided he was going to do. He was only going to give this particular medication. So one of the reasons that we know this thing about Norvasc, right, and you should give, lisinopril and things like that, disproportionately Black people, is because of pharmacogenomics. Like hypertension, yes, it can be impacted by diet, but it can also be impacted by genetics. So we're looking at the response of your body to these drugs, and some of it, yes, is based on your genetics. There's actually a field of genetic medicine where this is all people do. They try to figure out what drugs work for what type of people, right? Remember, I told you that sickle cell was a mutation? So a lot of times people with the sickle cell mutation cannot take this medication that they give people to prevent sickle cell. The medication makes them sick because they essentially have what's called sickle cell trait. So they can't take those quinolones. They make them sick. They just like they can't take them. And that would be pharmacogenetics because that sickle cell is like a single gene. So, gene therapy is largely experimental, but you want to try to use genes to treat diseases, to prevent diseases. Um, One form of gene therapy, some of it is definitely used with cancer. You think about when people are saying they're doing stem cell research, that's definitely a form of gene therapy. It's a relatively new treatment. Um, and like it hasn't, it's not one of those things that's kind of set in stone yet. Stem cells, cells in a body that can differentiate into other cells. So think about the fact that when a person gets pregnant, right, you start from two cells. And these essentially, this egg and the sperm differentiate into all of these different types of cells, right? This is why stem cells are so important because a stem cell can essentially become any type of cell that is necessary, right? It's not just like a stem cell is a cardiac cell and that's all it can be is cardiac muscle. Like, no, it can literally be anything. So the great thing about stem cells, because they are so multifunctional and multifaceted, is that they can grow into any type of lost tissue. Currently, the medicine is thinking about using them for like restoring function for chronic type of diseases. Like if you could somehow use stem cells to restore your myelin sheaths to reverse the effects of multiple sclerosis, like that would be awesome, right? You could use stem cells to reverse the effects of multiple myeloma when somebody goes into remission. right? You can use stem cells for anything. So one of the ways, and I'm not saying we're out here conducting genetic tests as nurses, but you just want to be aware of your patient's kind of family background. You want to be knowledgeable about that background. For instance, I guess my primary specialty is operating room. One of the important things to know before you put people to sleep involves their response to anesthesia. So we use propofol to put people to sleep, but there's a gas that they use to keep people asleep. And it's that gas when they're giving you general anesthesia that can basically it can cause you to start to react in surgery and you can actually die, right? So we ask people all the time, hey, have you had surgery before? No, I haven't had surgery before. Okay. Have you ever had any close relatives had surgery? Have they ever had any problems with anesthesia? Right? Because one of the things, and we're not just really talking about, some people have really bad nausea and vomiting, or their blood pressure becomes really low. But one of the things that we're talking about is malignant hypothermia. And disproportionately, if your mom had surgery and she suffered from malignant hypothermia, you could too, because it tends to be something that is passed on genetically. Another thing that you'll hear like nursing say, they always say, well, redheads wake up badly. Being a redhead is a recessive trait, but there's something else about being a redhead that make you react a certain way to anesthesia that anesthesia professionals are not fans of, right? So having this knowledge of the patient and their family history is really important. Because if we know that a patient has a family history of malignant hypothermia, they're going to change the way that they put those patients to sleep. So yes, Alicia, like having a good family history, having a good medical history, child, when you can get it, is really, really important. Not everybody is a great historian. Some people don't know what happened yesterday. Also, being able to educate your patient about how their family history impacts them today is also really, really important. So another thing, talk about family history. So if you have a family history of hypertension, right? Actually know somebody like this. Hypertension is just really like his family's thing. But he cut out beef, he cut out pork, he's largely vegetarian, he works out, he keeps his body fat down, like he has almost none, and he still is on blood pressure pills to keep his blood pressure down. So yes, there are changes in your lifestyle you can make, but if that hypertension is genetic, like you got it and you got it. So even though yes, he does things to manage his condition to keep it from being worse, right? And these are changes that he specifically undertook because he found out that he was predisposed to hypertension, that it was so bad in his family and he had such bad heart conditions in his family. But you can still see that he still has to take a medication every day to keep it down. So you also see this with like diabetes. You see this with quote unquote, heart problems. Um, all of these things have a type of genetic component. What? So, does anybody have any questions about this content? I feel like I've talked really fast. Nobody? Bueller? Bueller? Okay, well, We have said all the words for today and for tomorrow. So that means you get to enjoy your weekend and you don't have to come back here and learn tomorrow. So I recorded this lecture. The only thing I didn't record, and I'm really, really sorry, is that first video. But I did put the link in the video in the box, y'all. So I'm sorry I didn't record it, but the link is in the box. I'm a really big fan of videos, so I always I always try to show videos. Thank you, Miss Georgia. So good luck to you guys. You will graduate nursing school. I'm sure you'll find me here again one day. I kind of like lecturing. So if you don't have any questions when this recording is zipped up, I don't know if y'all recordings go on Canvas or on YouTube. Yep, no class tomorrow. You are free. Amen, saints. So I know that's right, Miss Ella. Receive it. So you guys enjoy your weekend. So you guys enjoy your weekend. Please make sure to do your questions because the key to passing nursing school is questions. All right, guys, be good. I will see you. Thank you so much for letting me teach.